Okay, Assalamu alaikum. So today we will be starting breaking bad news. You guys are aware, maybe aware of the term breaking bad news. So what do you understand breaking bad news? So firstly, we need to understand what is bad news. So what is bad news in your terms? Yes? Anything that might be inconvenient to the patient. Any news that can cause emotional stress. Okay, any comments from the female side? What is bad news? Yes. News that can affect the patient lives in the future. Okay, all right, good. Okay, yes, Fatah, you were saying something. Disease or any news that can affect the lives, that can be a bad news. So we will see what is a bad news, and then as a healthcare provider, you should be able to know how are you going to deal those situations, and why is it important to know about this skill. If you go into details, so we would firstly recognize the challenge of sharing the bad news effectively, and to be able to describe an effective 6-step process that can lead you how are you going to tackle the situation. Why is it important to know that? Firstly, we define breaking bad news. What is bad news? Why it is important to know this? And what is the problem in this? Yes, to be able to deliver in a way that patient is more compliant with the situation. Okay, so the compliance is one benefit that you're going to get as a doctor. Okay, so it's a common occurring situation or a condition, and we should know how to tackle this situation. Okay, but the question is, why is it important? One is that, okay, compliance with the situation. Release the pressure. Okay, to ease the pressure. Okay, so this breaking bad news situation is obviously an uncertain problem, which is or unpleasant problem, and there is a stress for this. The stress, this response, the emotional response, the physiological response, and we need to tackle these stressors, ease the stress. If we know what is the process, how should we do it, we would be able to better communicate with the patient and for the better compliance and to ease the situation of the stress. And by the way, stress is not only in the patient, it is also with the physician part also. And actually the stress is for the physicians. Responses of emotional responses are from the patient that you can expect, but the stress is mainly on the physician's part. Yes, any other comments from the female side?
Yes, doctor. Also, sometimes it's also accompanied by important decisions that the patient has to make. So we need to reduce the stress that the patient has so that he can make such important decisions.
Important decisions, yes, that's very nice. So if we deliver it in a way that is effective and constructive, obviously we need to decide off with the plan, because breaking the bad news is not the end of thing. We had to decide a plan with the situation. So in order to make a better plan, you need to effectively deliver the news and to deal with such situations so that you and patient can make important decisions. That's very nice. Any other important point? To adjust the management. Okay, so for the management of the conditions, you can also better communicate and better plan your management system. That's great. Okay, so this is the objective of delivering this presentation, and we will see how we are going to attain this. Bad news: any news that seriously and negatively alters the patient's view of his or her future. So it is any situation which can actually seriously and negatively alters the patient view, because the situation that you are in within these breaking bad news is not a very fruitful situation. So you need to expect these kind of behaviors from the patient. So in order to know, this is how we define bad news, but you can define the bad news as you guys have defined it. It's in a similar way. So why it is important? To help the patient and family understand the condition. So first of all, understanding of the patient and of the physician of the condition that this is which is going on. Support is the second goal. You want to support the patient and the families and minimize the risk of overwhelming distress or prolonged denial. So we discussed about distress. So we will take and tackle the distress, and we need to support so that we can have a plan. Patient have important decisions to make, so this is that requires support. And obviously this distress and support, you need also first you need to understand, to make the patient understand what is the problem and how he should deal with it. So why is it important? Is it an important communication skill? It's a complex task, by the way. It doesn't seem 1 + 1 2. It's very complex. Responding to the patient's emotional reactions. So whenever you're giving the patient a bad news, you can expect an emotional response from the patient. And mind you, not just emotional responses, there are aggressive responses also. So you need to be very safe at the same time while you're delivering the patient the bad news. Involve the patient in the decision making. So that's also one of the tactics that you are going to use while you are delivering the news to the patient, that he should be involved in the decision making. Dealing with the stress created. So there is a stress. There is no doubt about the fact from the physician's point of view and also from the patient's point of view. Involvement of the multiple family members. So that's also a very complex situation if you're dealing with in Southeast Asia. So we have family involvements, we have family structures, so you cannot avoid them, and also you cannot breach the confidentiality at the same time. So we need to create a balance between these two, not just ignoring all the family members and not just outreachly including all the family members. How you should deal with it, that's the tactic that you need to learn. Yes. Any family member, any first degree or second degree, it depends on the family structure. Some people are more close to their aunties and uncles, so whatever is there. But we need to involve, we need to consider them if it is relevant. If it is not relevant, it's a patient who is living singly and doesn't have any family members, that's fine. But the problem here, the challenge here is when there are family members involved in it and they actually do not want their loved ones to be aware of the conditions. Then what should we do? How should we do it? Should not do it, or we should do it? So these are all questions we doesn't have simple answers. Yes. Yes. So obviously, if the patient is deceived, so obviously you need to involve the family members in that way. You have to involve it. But how are you going to involve this? That's actually the thing. You cannot make the challenge is you cannot make a bad news a good news. It will always remain a bad news. But the thing is, you need to create a news which is acceptable to the patient, and then you can look forward how are you going to deal with this situation. And to give hope when situation is bleak. So you need to create a hopeful environment, but not an unrealistic environment which makes it very happy news. So it will remain a bad news. So try to do not make manipulative statements where you can say, okay, if it's a terminally ill patient, and you can say, okay, no, it's okay, everything's going to be fine. Everything cannot be going to be fine, but whatever is the problems, we have some sort of solutions to make your conditions better. So why is it critical? So first we discuss about the critical. If you think about the patient's perspective, patients often have vivid memories of the receiving bad news. So they usually do not understand, and they actually expect this bad news to be delivered very badly from the patient, from the physician. So they are so if they have this perception in their mind, so they become very aggressive, they become very defensive, they may go into denials. So this is their own self, that this is the bad news, and it has to be wrongly delivered from the physician. So they cannot accept it. They have some negative experiences, can have lasting effects on anxiety and depression. So patient you are talking to may have some depressions, some anxiety issues, so personality problems. Some patients are very aggressive to begin with. Some attendants are very aggressive to begin with. So you need to understand, if you're talking to the patient and the relative is getting angry, then obviously you cannot attend the angry relative and a sad patient together. So you had to differentiate, and you had to separate all those issues, and you can deal it one by one. How are you going to deal it? This is your skill. You can understand the situation, understand the family structure, and then you can deal it one by one in order to address the anxiety, depression, aggression, denials, these kind of things. What you can do is can facilitate adaptation to the illness and deepens the patient-doctor relationship. So if you make it very good, breaking bad news to the patient, it is going to actually strengthen your relationship. But we as physicians, we think that, okay, my God, this is a very bad news, and it's actually my failure. So I should not deliver it very confidently, or rather I should just do it very quickly. So that's not which is going to work. The thing which is going to work is if you own the situation, handle the situation. In this way, you actually deepen your relationship with your patient. Why? Because you're very confident, and the patient sees support in you. That's one opportunity that you can make a good patient-doctor relationship. It is a difficult task because it is frequent and stressful. This is what we have discussed. And most patients want to know the truth. We are required to tell them what they desire. The truth is unpleasant and will upset them. We are anxious and fear negative evaluations. So we discussed that it's a known fact that this is a stressful situation, and we need to handle the situation in a way which is acceptable to the patient, and so that we can deal with the anxiety, deal with the depression, and deals with all the problems. So it's actually a burden for the physicians, and the recipient is already distressed. We don't want to make things worse. We want to be honest, but not destroy the hope. So you need to be honest. You can give hopes, but that hope should be realistic, practical, achievable, and objective oriented. You can't say that, okay, you're going to be fine. Yani, if the patient has diabetes, you cannot say that, okay, your diabetes will be controlled, your diabetes will be managed and cured. No, it can be controlled. Cured is a wrong word. Terminally ill patient, everything we can treat everything. No, we cannot treat it, but we can manage it. So we want to be honest, but do not destroy the hope. So everything cannot be done, nothing cannot be done. So it is always you need to be honest, but you can be hopeful. So we are therefore reluctant to deliver the bad news. So this is why we as physicians, we think that if there is a situation to the patient, we think that it's a failure to the physician, and that's why it's our anxiety level goes up, and then we actually destroy the situation here. What do you want to achieve from there? To gather the information from the patient. So first thing first, you need to gather the information. The more information you have of your patient about the personality, about the disease course, about the test that has been done, and things like that, the better you are going to be in order to manage the situation. To provide intangible, intelligible information in accordance with their needs and desires. So you want to create a patient's desire, and so that you can manage those situations better. Yes. You need to be honest in this, and the situation that he is referring to is a patient who is you newly diagnosed a patient with diabetes, and now you want to break this bad news that you have a diabetes, but because of the fear that the patient will go into denial that I don't have diabetes, and he's very anxious, and he was maybe very depressed, and you wanted to make the patient feel good. So in that way you want to create some hope, and within this hope you can ask the patient that, okay, initially we are giving you some medications that is going to make you feel better, make your diabetes going better, and then after a while everything is going to be all right. Actually, this is not, the thing is, what you are breaking is not important. How you are breaking is important, number one. Number two is, if there is a patient who has diabetes and you wanted to start off with a condition, whether it be a diabetes with medications or insulin, whether it be a patient who has CKD and then he is going into dialysis and is a chronic kidney disease patient, so it's also a very dilemma, it's a traumatic kind of a situation. You can provide them the hope, but that hope should be realistic. Curing with the diabetes is not something which is a good thing. Controlling, if you manage, how? Look, we had to start with these medications, otherwise this diabetes is also going to be more worse than this. But alhamdulillah, this diabetes has not giving you is not affect your kidney up till now, is not affect your eyes up till now. So sandwich technique, good thing. Within this you have a diabetes, and then again a good thing or a hope that, okay, alhamdulillah, that it is not with the complications, so we can still manage it and control it. You can say this one, if you have we will start with the medications, but if you remain compliant with the dietary thing and the physical activity, we might not need to increase the medications. And hope maybe if you will become very much compliant with your diet and physical activity, we can even reduce the drugs, and we can even fade off the drug. So that is going to give the patient hope and motivation to do physical activity, to restrict himself with or herself for the dietary thing, because he wants to get rid of this medication, which is a diabetic medication. And this medication is only there because I'm not having a good healthy lifestyle. So you can use this tool to motivate the patient. Later on what happens, only Allah knows. But you can motivate the patient, and you can say it in this way, so that patient is going to be motivated to do these kind of non-pharmacological treatments. Okay, so this is how you can create your own consultation style according to your cultures, according to your beliefs, according to your faith. If the patient is non-Muslim, and then you say that, okay, Allah is going to make it, everything's better, obviously it's not going to work. you have to you have to be rationalize and contextualize your conversation. If you are in an Islamic country and you have Muslims who have a very good belief and faith, so you can now include your counseling skills with the faith and Allah's maslihats and things like that. Look, okay, now why the physicians are very, very much anxious, and when you go into your internships, you will realize that you are the person who would put forward. The consultant wants to put you guys as forward forward rescue plan, that okay, now you are an intern, you should go and tell the patient that he has carcinoma colon and he has diabetes or whatever, or we have this complication after the surgery. So as an intern, a junior fellow, you had to go and deliver the patient. Why is it going? Because the physicians has a high degree of difficulty. They have their own anxiety that this is actually my failure, and if I had to say this, it's going to be my failure. Don't take it as a physician's failure. We had to understand that this is a medical condition which can happen to anyone. So that's actually making things more complicated with the patient and the doctors, and the high risk of performing poorly, physician's anxiety. So the more the physician is anxious, the worse is going to be the outcomes. So you need to be very careful in this, and you need to aware what is the procedure and how should I go it as a physician. So what is the expectation? If you meet the patient's expectation, the things is going to be normalized. What is required? And if you see here, there is nothing like as good management. The thing which is here is, for themselves, patient needs more time to talk and show feelings. So patient wants to be expressive to you. Patient needs more time from you, not a good management or this medication or this medication or this therapy or this therapy. No, they just need time. They just want to express their feelings. Once they are over with their expressions and the feelings, now they are going to think, and this is their intellectual need. So first you need to address the patient's emotional need or psychological need. Second, the intellectual need. What is the intellectual need of the patient? To get some plan, to get some alternatives, to get to know about the prognosis and things like that. But first thing first you need to normalize the patient with their emotions. If you think that the patient needs more time, you can give more time, and if it is not possible in this outpatient clinic that you have just 10 minutes for the patient and there are 20 patients waiting for you, you can ask the patient, okay, maybe we can discuss this in a later consultation slot, so that we are in a better situation to discuss all this situation. So you can ask the patient to get another appointment. What from the doctor? More information, caring, hopefulness and confidence. If the patient see that you as physician is confident, okay, whatever happened, but no problem, we have ways to deal with it. So the patient will feel also confident. Okay, now the physician knows it. But if the physician is just, I don't know what to say, and inshallah we will do it, and then skip things up and avoiding the main conversations, it's not going to help. Actually, it's going to destroy the patient and your confidence also. So you should be hopeful, confident, and you should carry out with some caring attitude. So first we need to start off with the getting of the information. So you're starting a patient with a consultation, you entered into the consultation room. What first thing you need to know? You need to gather the information. Okay, this is your information, this, you have done these tests in the past, I can see, and you have done these managements, and these managements won't getting you better. So getting the information from the patient, or ask the patient what have done previously. So maybe the breaking bad news you're going to deliver to the patient already knows it. So that makes your life easy. So he already knows that, okay doctor, I know that why I have carcinoma colon, how should I go about it? So now you know that, okay, the patient knows that. he has this cancer. Then I need to focus on management plans and options and alternatives and prognosis and things like that. So you don't waste your efforts into those things which are already known to the patient. So you need to get the information from the patient. Ensure the family support at the time of breaking the news, and find out how much the patient already knows it. So you can get a patient's family's involvement, but after the patient consent. If the patient family member is coming to you and asking you for something, asking you for an advice, or telling you to ask the patient to tell this is not acceptable. But rather, you can explore that relative that why do you want to hide this information, for example, and things like that, and try to focus on your patient, but do not ignore the relatives, but do not over entertain them as they are the patients. So you need to create a balance between not to entertain and to entertain properly. And while you're giving the patient information, you also need to fire some warning shots. I'm afraid that I have not a very good news for you. These are the warning shots. Find out how much the patient wants to know. There is also a problem that the patient doesn't want to know everything, and if the patient chooses not to know everything, that's okay. It's his choice. So share the information. Give the information as small chunks. You need to educate the patient. The more you educate the patient, the more you give the information to the patient. Patient is in a better position to understand the situation. Okay, so the cancer is like this, the diabetes is like this, and then you have this. But you need to consider that the patient is a patient, and you don't use medical words, medical jargons. The patient is understanding, so you can offer in between summarizations. Yes. The question is, if the relative knows the bad news before the patient, and he asks that, okay, do you mind if I break the bad news as a relative rather than you? So what should we do about it? One colleague is saying that, okay, it's the doctor's responsibility, he should do it. The other one is saying that, okay, you can involve the patient. Yes, you were saying. Okay. Go together. Together. All right. Physician is better in that way that you can discuss the more management plans. There was some rising hands here also. Physician responsibility. Okay. Yes. So first the doctor and then the patient, then the relatives, and then we can go together, things like that. Okay. All right. Okay. Any comments from the female side? What should we do on this situation if the relative wants to break the bad news?
We can ask the patient how he would like to receive the information. Does he want to, there is a bad news, does he want to take it, or yes, or you want your relative to?
Yeah, but the thing is that the relative has already know the situation. Then he went to take the biopsy report, and then he pull the report, and he sees by himself that he has carcinoma. So actually here the doctor did not break the bad news. Firstly speaking, doctor should not break the bad news to the relative. Number one, if the relative comes to you with the report, not with the patient, and says that what is written here, I need to know so that I can deliver the patient this news, that is not acceptable. You cannot ask the patient, you cannot rely on the informant or the relative, okay, I am now giving you the news and then you can deliver it in a better way. No, this is not acceptable. But, yes.
We need not to tell the relatives. We ask the patient result of the biopsy?
Yes, that is fine. If you are with the patient and the patient comes to you, and then you can ask from the patient, do you want your other relatives to be with you or not? If the patient allows your father, your mother, your brother, your cousin, that's okay, that's patient's, but that's patient's thing. But here is the patient's relative is here and he has the biopsy report and he wants to know what is written in this report. You are not going to tell to the relative, okay. But if relatives already knows and understand, okay, this is cancer written, doctor, I know that this is cancer, and do you mind if I can break the bad news? You don't say yes and you don't say no to the patient, and you don't say, you cannot further discuss this management plan and all that with the relative. You are first thing first, you don't know whether the patient, whether the relative you as physicians are encountering, is he the person the patient is going to allow in his management plan or not. We don't know about that. In the first situation, we know that okay, the patient is allowing this relative to be in the management plan. Here you don't know. You cannot trust that relative that okay, no doctor, he's my brother or he's my son, he's my cousin, and we have a good relationship. You do not want to accept this reality on the relative's face. You had to call the patient. Maybe you can call at that time that it's better, you should call the patient in front of me and you can discuss whatever you want to discuss, so that you can go all together, number one. Or you ask the relative to call that patient, and you can ask the patient that okay, we have not a very good news for you, and how do you want me to proceed? Do you want some other person to involved in your care plan? If he says yes, okay. If he says no, even though that relative knows that I know it, but since the patient says that and you did not breach that confidentiality, the attendant by himself breached it and he wants you to involve in it, you are not going to involve in this situation until unless the patient gives you the right that okay, doctor, no problem, he's my brother, he's my son, he's my cousin, and I'm comfortable sharing the information. Only then you can allow the patient to that attendant to involve into the situation. So that's how you need to first thing first, you had to concentrate on your patient, but you cannot ignore the relatives. That's actually the challenge. You need to respond to the patient's feelings, blend your agenda with the patient's agenda and offer hope. So while you are breaking the bad news, what targets you want to achieve? You want to see there are some plans that the patient has in their mind that before I have this surgery, I need to, for example, I need to attend this wedding. And so you need to respect this, and then you can put it in your agenda. Okay, no problem. After the wedding ceremony, maybe we can have the plan for the pre-operative surgery and things like that. So you can blend your agenda with the patient's agenda. Listen for the patient's concern. Maybe the patient is concerned, over-conscious about anything. Maybe, for instance, the patient is diagnosed with tuberculosis, and he thinks that the tuberculosis is a deadly disease, and everyone who or the patient has corona, and he thinks that every person who has corona is going to die. So that's a wrong perception actually. So that you need to normalize the situation that okay, you have a corona, but that's okay. If there is no risk factors attached to it, you're going to be fine. The mortality rate is this, and things like that. You can give these kind of hopes, realistic hopes. Reinforce and clarify the information frequently. So you need to clarify if the patient is understanding appropriately or not. Use the appropriate language, whether it be in English or in Arabic or anything which is relevant to the situation. You need to ask for this kind of language barriers. Warning shots are very important. So now we stick to the protocol, which is called Spikes protocol. Does anyone knows about it? SPIKEs. S is for the setting, environment. Okay. S is for that. P for privacy. Okay. Preparation, privacy. Any other comment? P is for perception, patient perception. And then we see I, and then K. Anything with I? Information. Okay. K? Knowledge. Okay. E? Emotions. S? Summary maybe. Okay, let's see that. So S is setting up the interview. You make sure that the patient does not caught you into the corridor or in the elevator, in the cafeteria, outside the washroom. These are very inappropriate places where you can discuss these information. So setting up a very good interview place where it is quiet, confidential, you are relaxed, patient is relaxed. So these are all environmental factors. Assessing the patient's perception. So P is perception. What patient knows about it. How are you going to assess perception? What questions you are going to ask for the perception, to know the perception? What questions you are going to ask? You ask for with his son, the patient's son. Okay. If there is a support present. Huh? Expectation of the patient. Expectations of the patient will come into the perception is not the expectation. Actually, expectation is a different thing. Perception is a different thing. Patient perception. And what are the questions that you can pose to the patient to know the perception? What specific questions? Perception is actually, first let me give you, perception is the patient's understanding of the disease. Okay, yes. So what tests you have done, what you already know about the condition, why you are here. So you are asking these questions. The same thing. Huh? Misinformations, yes. So perception will also tell you about the myths that the patient already have, and how, and when you know that okay, this is a myth, you are not going to upfrontly say that okay, no, this is wrong. You just ask the patient to open him or herself to you, to know what does he know about it, what is his understanding of management, what is its understanding of the disease and the conditions. Then obtaining the patient's I is for invitation. This perception also encompasses the information the patient has already. You are not going to give the information. It is the baseline knowledge of the patient, baseline expectation of the patient. Everything baseline of the patient you are going to explore in the patient's perception. The other thing is patient's invitation. You ask the patient, how much do you want to know? I is invitation. Then this is at the third stage, you are going to give knowledge and information. So based on patient perception, the whole knowledge that he already has or she already has, then you ask the patient the invitation that do you want to know the whole of it or just the gist of it, or you want your caregiver to involve into it. Ask the patient's invitation. And then you will give your knowledge and information, what is required, what is missing, and if there is any myth that you identify, if there is any gap that you can see. Based on that, you give the patient the information. Then addressing the patient's emotions. Once you give the bad news, obviously you are addressing the patient's emotions. or there must be some sadness, there must be something which is uncomfortable, there must be denials going on. So you need to address these emotions. So E is for emotions. S is for strategy and summary. Once this emotional thing goes up, then your intellectual work comes in. You identify some strategies, you give summaries. By the way, these summaries can be in between or at the end also. Depends on your understanding the patient's relationship. So you need to identify your strategy and summary. Be mindful that all these things cannot be achieved in a single consultation. It's okay if the patient is very emotionally unstable and is in a denial stage, you stop your consultation, because if the patient is in denial stage, if the patient is already angry, he is not going to sit with you and decide strategy plan. There is no use. So if you think that you and your patient is not in an ideal relationship where you can come up with a strategy and a plan, you can stop this consultation. You can ask the patient, do you want another consultation? Maybe we can talk this another time. Or you want another physician. Maybe you are in a denial stage, or you are not satisfied with my communications and things that we do it. We can refer you to another consultant. Maybe he can guide you in a better way. So that can also be done. But depends on the patient and doctor relationship. You will identify whether this is strategy and summary is relevant or not. Summary is is always relevant. So if we see here, setting up an interview, preparations, plan, privacy, significant others, setting, non-verbal behaviors are very important, and the time is also very important. So your non-verbal behaviors and the time is very important while you are setting up something for breaking the bad news. Patient's perception, gather before you give. Patient's knowledge, expectations and hopes, whether it be a realistic hope or non-realistic hopes. Expectations, realistic expectations, non-realistic expectations, you jot it down, everything. When you are giving your information and providing the strategy plan, you can use all these informations. What do they understand about the situation? Some unrealistic expectations. What is their state of mind? Are there any hopes? Opportunity to correct misinformations and tailor your information, but this should be done in a very smart way, so that the patient doesn't feel confronted or uneasy. Then the patient's invitation, how much the patient wants to know, and answer the questions, offer to speak to another. So if the patient wants this, the extent of knowledge that he wants to have, then K is for giving the knowledge. This is based on the information that you give, and the knowledge would have warning shots with it, use simple language, vocabularies, small chunks. You need to allow pauses, allow information to sink, wait for the patient responses, check the understanding, check the impact. So you don't need to fulfill all the spike protocols in just one consultation and go away. So if you are dealing with the knowledge giving, you make sure that the patient is understanding. If the patient is crying and then you are giving the whole knowledge, there's no point. If the patient is crying, you need to stop. You need to offer some help. You need to give some water. You need to give some tissues. You ask the patient maybe to go out and have some rest. Within these information, while you're giving the information, you need to check the patient responses, check the impact, whether the patient is understanding or not. If my voice is clear, if my words are clear, if he needs any clarification of my words, of medical words that come out from my mouth unintentionally. So you need to also understand the patient, your knowledge why you're giving to the patient. Then addressing the patient's emotions with an empathic response. What is empathy and sympathy? Difference between sympathy and empathy? Feeling with the same feelings, empathy. All right. Okay. Yes, you were saying something. Last one. Yes. The same, huh? All right. So empathy is a little bit higher thing, and it's the same feeling that you are actually you're actually putting yourself into the same situation, and then see how the patient is feeling. So empathy is a more stronger term, you can say. You can have shocks, you can have isolations, you can expect from a very good, a very very bad grief, silence, disbelief, crying, denial, anger. Observe patient's responses and identify the emotions. First, you need to know what my patient is suffering from, and then based on that, you can create your own plan. If the patient is very aggressive and he wants to hit you, and you're trying to make some strategy plan with the patient, it's not a good time. You first need to protect yourself. You first need to ask the patient to remain quiet, remain calm, and after that, you can go on with that. So offer empathic response to the patient, okay, yes, with the words that can make the patient more relaxed. Then there comes with the strategy. So you need to, while you are doing the strategy, you need to know whether the patient is ready or not. Involve the patient in the decision making. Check the understanding, clarify the patient's goal, and then summarize and contract for the future. So first you need to understand whether the patient is because this strategy is actually very important. And if you think that there is already a lot of information that the patient already has it, you check the patient information, then you offer some warning shots, then you give your information, then you fill the gaps, then you also address some misconceptions, then the patient's agenda and things like that. And if you think that it's too much for the patient for one consultation, you can ask for another one, and then decide for the strategy and plan. You can strategy would include the referrals, the specialities that requires the help, the prognosis and things like that, and then summary at the end of all the consultations that you've done. And you also need to provide some contact numbers or some important numbers for the patient to follow up with these plans. Yes.
So when the patient is choosing an option, giving options for the patient, we want this way of believing or that way of believing. The choice he made, which is
it? Summary? Can you repeat your question, please?
The way we are discussing the options, give the patient the opportunity to choose which path or option you want to take.
Yes. You can do it not in the summary. You can do it within the strategy. Within the strategy, when you are making the strategy, you involve the patient into the decision making. That okay, first you give the options that you have this, and then you ask the patient, okay, these are the things that are there. Do you understand? First of all, number one. Second thing is how do you want us to proceed with that? So involve the patient within the strategy while you're making the strategy. Don't make the strategy and ask the patient to follow this. This is not the way. You first develop the strategy plan based on the consensus, and then we as team, like patient and us, are going together to achieve the plan. This is how it should be. It's not just the directive thing.
For example, if we discuss the strategy with patients, especially for prognostic opportunities, like how far should we offer the data? For example, patients with terminally ill conditions or maybe high stage of cancer. Usually in the community, they say that these patients will live no longer than 6 months. So should we bring it here, or how far should we deliver it to the patient?
It depends on what the stage is. So once, if you are a GP, okay, and there is a patient with coronary carcinoma and the biopsy report says that, or if there is an endoscopy which says that this patient has this mass which is suggestive of adenocarcinoma, things like that. So even you as physician does not have the full knowledge of what kind of cancer is this, what is the prognosis, because squamous cell carcinoma, adenocarcinoma. We have different things. If you do not have the knowledge, you won't be able to give to the patient. You can ask the patient, okay, if the patient asks you that, okay, doctor, if am I going to live longer or not, you can ask the patient. I think that at this stage of time, we are not in a very good stage condition that we can say that, okay, what is the prognosis. But once we refer to there and we have done some tests, after that we can in a better position to say that what is the prognosis. Or you can ask, I would be referring you to the general surgeon or the oncologist. Maybe he is in a better position to answer this question. If there is a knowledge gap between you, so that you can ask that, maybe we can, I'm referring you to that physician, he is in a better position to tell you this question. Yes, same, all right. And contract for the future is also very important. You ask your contract for the future. That means that you give some information that within the few months you are going to see these doctors, and this is how we are going to do it. So remember, your colleagues, physicians as patients are just as vulnerable. If you are vulnerable, then patients who are not physicians need our friendship, encouragement, help and hope. And then there is continuous, comprehensive, compassionate, coordinate, competent. So as physicians, you should be very competent, compassionate and empathic to the patient. And it seems like you first, as a physician, you first need to assess yourself. Maybe you are in a very hurry situation. Maybe because we physicians are also humans. We have different feelings. Maybe we are very agitated. Sometimes we are not very good mood to interact with these situations. So we interact. We do not realize that we are in itself. I'm very overloaded, and I'm post call, and I have overburden. I have a very bad relationship with the senior consultants, and that situation, this kind of situation comes in, is going to blast. So you need to assess yourself also as a physician and try to normalize yourself, and do not try to medi-speak like blast cells, like leukemias, demyelination. We use our own languages which is not understandable to the patient. So make sure that you do not use medical jargons. What are the do nots? So we are done with do's and don'ts, the plan. Now we go on to the do nots. Lie or fudge. Get your facts wrong. These are the things that you should not do it. Okay? Break the bad news in public. You should not do it. Give the impression of being rushed or distant. So you ask the patient, okay, what is the point? If the patient is just asking you, doctor, I was not expecting this, and I'm very depressed, and I have this problem, and then you say, okay, fine. What is the problem? What do you want me to do it? So don't make the patient realize that you are in a rush or hurry situation. Give the impression of being rushed or distant. You should not do it. Interrupt or argue. You interrupt in between to the patient. You should not do it. Say that nothing can be done. There is always something can be done. Okay? And this is also not very good that you say that everything is going to be all right. Everything is not going to be all right, but something always needs to be done. So there is always a hope. You need to be mindful of your words that you're using. Anger with anger, I just said that if the physician is angered by himself, then he is not going to create this good conversation. Say you know how they feel it. You cannot actually know how they're feeling it because you're a physician in a way, but you can understand how they're feeling. Don't be frightened to admit you don't know something. If you not know about the prognosis, it's okay to say that, okay, I do not know it, and maybe later on we can discuss this issue. That's fine. But if you lie things up and making your own facts, it's going to be very difficult. Medical jargons, you do not use medical jargons. Leave the patient with no follow-up on contact. You must have to have a follow-up in your strategy. Agree to withhold information from the patient. So you agree with the attendant that you are not going to tell the patient that he has cancer. You cannot do this agreement. Yes, if the attendant comes to you and says that, okay, do not tell the patient that he has cancer. I know it as an attendant that he has cancer, and you ask the relative, okay, no problem, I will not tell the patient. And just you don't tell the patient without his consensus. You need to involve the patient. So you do not agree to the attendant for withholding some the information. So these are all the don'ts that you as family physicians, you are going to, not as family physicians but as doctors, you should know that how you are going to do it, and what areas you need to focus on. Any confusion so far?